Everybody, we're just waiting for people to come online. Everybody's logging in. We'll just wait a couple of minutes before we get the show running. For those of you interested, I'm in the Judean desert. I thought that'd be the appropriate place to be during a time of COVID. Abraham did his gig out the back there somewhere, and I think Monty Python did too. So you can take that from that what you wish. But we're still waiting for people to come on stream. Wait a couple of minutes, and then we'll get the show rolling. Right, the numbers seem to be stabilising at around 56 at this stage. Caitlin, are we stable at 56?
I think we can start, Sam.
Okie doke. Well, thanks everybody for attending this, the second Service Providers Conference webinar. Today we're looking at frontline service responses during COVID-19. I'm here to just be one of the bookends to the gig and to welcome you all. Today's session will be recorded and we'll be posting it on YouTube channel AOD Victoria. So I'll just hand over to Rebecca, who will get the proceedings moving. Thank you.
Well, everybody, welcome. I'm Rebecca Lorains. I'm the CEO at Primary Care Connect and also the president of VADA. So as Sam said, the theme of this webinar is frontline service response during the COVID-19 with selected perspectives. So this webinar will provide insights from frontline and consider the implications for the broader AOD system, and importantly, how we understand the impacts on our consumers. Firstly, I'd like to do an acknowledgement. So in keeping with the spirit of reconciliation, I wish to acknowledge the traditional custodians of the land on where we meet. I wish to pay my respects to their elders past, present and emerging, and extend that to any Aboriginal person with us today. I wish to acknowledge the important role Aboriginal and Torres Strait Islander people continue to play in our community, and that this land is and always will be traditional Aboriginal land. So before I hand over to Scott to moderate our first panel, I just wanted to remind people that we're using the Q&A function. So if you hover your mouse over the bottom of the screen, you'll see the Q&A. And we ask that you ask all your questions via Q&A, and also that you ask questions. I noticed in the last webinar there was a fair few comments or statements, so if we can just keep them to questions, and if your comments, maybe you could put them on the chat function. The chat function is available, though we won't be moderating it for questions, so if you have questions, please use the Q&A, and the panellists and our guest speakers will pick them up from there. Like everything, we can like it, give it a big thumbs up, and that will upvote. That's a new word I learnt this morning, upvote. So we can upvote something if you like a question, and that question will rise to the top. So without further ado, I will hand over to Scott, who is going to introduce our panellists.
Thanks, Beck, and good morning, everyone. Thank you for joining us. I might ask, I'll make a few comments, but I might ask the panel, Sione, Suzi and Sarah, if you wouldn't mind turning on your cameras. Great, thank you. Okay, so thank you. So I'm really pleased and excited to join in a conversation. I'm going to ask a few questions of our panelists, but really I'll be in the background. You, as attendees, can ask questions, and I'll try and facilitate, moderate, and look to those, and in between the questions I put to the panel, we'll try and take your questions as well. I'm Scott Drummond, I'm the Program Manager at VADA, and it's my pleasure to introduce Sione Crawford. Hi Sione. Sione is the CEO of Harm Reduction Victoria. He has been working in community and peer-based organisations for over 15 years in a variety of roles, from policy to peer education to management. Excuse me. And prior to Harm Reduction Victoria, he managed the ACT user organisation and was Programs Director at the New South Wales user organisation, and brings a wealth of experience to this conversation. Thanks, Sione, for joining us. Suzi, hi, how are you? Thank you for joining us too. Suzi is the Deputy Director of the Monash Addiction Research Centre in Melbourne and is a current NHMRC Career Development Fellow. Suzi has been a registered pharmacist for over 20 years with clinical experience in the treatment of substance use disorders, and was central to, in fact, and this is why, one of the reasons at least why we've invited Suzi to be a part of the panel, was central to the early response to COVID-19 and pharmacotherapy. And so I'm looking forward to hearing Suzi's comments on how that was managed when things first hit. And Sarah, hi Sarah. Thank you for joining us too. Sarah currently manages PAMS, the Pharmacotherapy Advocacy, Mediation and Support Service. And as a program of Harm Reduction Victoria, PAMS is a statewide telephone-based service for pharmacotherapy consumers and direct service providers, a really critical service, in fact. And Sarah has a keen interest in social justice, so she shares that with the other panellists, I would expect, and me. Consumer advocacy and peer education, and she's worked in the AOD field for approximately 20 years. So between the panellists, we've got at least 60 years worth of experience. So, you know, it's a real privilege to be able to have you online. So this is going to be a conversation about pharmacotherapy and COVID-19 and at that intersection. What did we anticipate? What did we do? What's happened, and what can we learn and what can we take forward? And I'm particularly interested in that question because I think there's a window of opportunity here to think about pharmacotherapy going forward, triggered by COVID-19. And my sense too is that DHHS, and for those that joined us and, or on another webinar, heard Martin Foley, I think there's an appetite for exploring options in this space and system reform at least. So I'll kick us off, if I may, and hand over to the panel, and then I've got a couple of questions as we go along. So thinking then about the context and when and where we started, and COVID-19 and what was happening and the concerns that were generated, I'm wondering what were some of the original concerns around the pandemic and pharmacotherapy? How did we understand and how did we consider and make sense of and think about what to do at that point when the coronavirus took hold and we needed to think about consumers, pharmacists and GPs? What were some of the original concerns? Suzi, maybe you could talk to that to start with.
Yeah, look, I think that we're very lucky to have a very engaged sector, and very early on, people like Rob Weiss and Frankston, sort of high volume prescribers, were flagging that they could see issues emerging and were very concerned that if we didn't get onto this and have a prepared response, that it might mean that it would be hard to provide continuity for people in pharmacotherapy treatment with some of the changes that we were expecting, and also that we wouldn't be able to support people in pharmacotherapy to be able to social distance and stay at home as we've all been advised to do, and also that we wouldn't be able to reduce the potential impact on sort of crowding in pharmacies and GPs by not taking advantage of setting up some systems in advance that would reduce the pressure on needing to attend those services face-to-face, etc. So I guess that's where that early response came from. And I think we were very lucky that it came together in a very multidisciplinary way, with VADA facilitating a range of working groups that had a whole range of knowledges in the room to really kind of, I guess, talk out between us what we saw as the key issues that might impact on people who are either in pharmacotherapy already or who might want to be in pharmacotherapy, as we saw some of the potential changes around drug markets with COVID, and how we might be able to put some changes to current practices in place early. So I guess that was the process of having a whole group of people coming up with ideas, and it might be good to throw to Sione and Sarah, because I think they were fairly, Sarah in particular was on those groups, and her voice in terms of identifying the issues that consumers were already facing in terms of some prescribers recognising that it would be good to have more takeaway doses, for example, so people didn't need to travel and be out and about as much. But perhaps pharmacists being concerned that that was outside the current policy, and being advised if you give more takeaways than the policy allows, then you won't have any professional indemnity insurance. So we did have some really kind of very real challenges that we needed to overcome pretty quickly. Sarah, did you want to speak about that from what you were seeing at the time?
Yeah, sure. I mean, interestingly enough, and I mean, it's completely understandable, but one of the biggest issues was there was a lot of panic about the methadone running out. That was a sort of a big fear amongst the consumer group. Initially, as you pointed out, lots of concerns about having to catch public transport, and not only catching public transport, but being in a pharmacy, often waiting for your dose with a number of other people who are also there getting medication and then quite possibly sick. So we were sort of getting reports from a lot of the pharmacotherapy consumer group around those issues, and quite a lot of sort of, fear and I guess panic, which understandably comes from the general media. And just sort of how are we going to keep dosing? That was the biggest sort of initial fear.
What about stigma at that point in time? Was that something on your mind, or was there something in that space that you wanted to think about?
Yeah, I mean, sure. Like as Suzi and Sarah were really heavily involved in being part of doing the guidance, I'm happy to leave a lot of that stuff to them. But it's definitely the case as a pharmacotherapy consumer that often you've been part of you're already part of a criminalised group and community already. And that memory doesn't leave you, and to know that that you may need to go out into public and may be not able to isolate as often as others. So often, as you know, people have to go to the chemist every day to pick up their takeaways, pick up their doses, I'm sorry. And so feeling like you were red lighting and feeling like you have to go out into public more often than others, and therefore come to the attention of the police more often, is a very real fear, and the long years of stigma that most of us have faced certainly played into that fear that Sarah was talking about, I think.
Yeah, absolutely. And I mean, aside from this, there were other sort of little issues, like, very soon after the pandemic kind of started and ramped up, an example, like a lot of pharmacists were not wanting consumers to recycle their takeaway dose bottles. And this was leading to a lot of concern, because pharmacies were, charging for a new bottle. And that, in the case of somebody getting, 4 takeaways a week, that's suddenly an extra $8 a week on top of the dosing fees. And I think that something like that sort of plays into a bit in the stigma, like, this was fine before you accepted my takeaway dose bottles back, but now you don't want to touch them. And that sort of, oh, okay, kind of, yeah. So it's delicate and it's difficult, a lot of this stuff.
Mm.
Yeah, I think it also came into some of the messaging, because we certainly don't want to imply that this patient group is a patient group that is any more likely to put anyone at risk, but it is a patient group who is more at risk. And so we really need to make sure that for people who have respiratory conditions, any of those comorbidities that might put them more at risk, that we really make it as possible as we can for staying at home, not having to get onto public transport, all of those things that were recommended for everybody else. But it's just a little bit harder if you're in a treatment that requires you to attend every day. And I guess some of the other issues around risk relate to, I guess, social isolation and overdose risk. So if people are on their own, we know that there's been a lot of talk in the media about people drinking more alcohol when they're home on their own, due to anxiety, due to some of the mental health challenges. Those same kind of concerns can affect people with other substance use as well. And so trying to balance having people at home, but also make sure that people are safe if they're not seeing people face to face as often, that that we have other mechanisms so that people can get support when they need it. So there's I guess a lot of really a lot of kind of tensions that are really, there's two sides of the coin in terms of keeping people at home, but then there's risks with being at home. And it did require, I guess, and we'll continue to have a lot of nuanced thinking around how we can do things differently, but hopefully not without adding any additional risk to people, or where there is additional risk. So for example, with takeaways, making sure that naloxone is available and that we're able to offer that. So there has been a lot of very quick thinking and adapting about all of the different ways that this could affect people and what we could do as healthcare professionals, as the Department of Health, what they could do, and all of the things that could be put in place. So I actually think for Victoria, where we were incredibly lucky that we acted early to get these things in place. We're also very lucky to have a really coordinated response and discussion. I know that not every state was able to do that, and we have had interim national guidance that came out after our Victorian guidance, but are pretty consistent with that. But some states, their pharmacists don't necessarily have the state-based guidance that protects them like we do in Victoria.
So maybe you could talk to that. What then happened? Thinking about that context and thinking about the tensions that you mentioned.
Yeah.
What was put in place? What happened next?
Yeah, so a couple of key documents came out that were put out by the department, and that was seen to be a critical step in terms of having that be recognised by all of the healthcare professionals that would need to work under that guidance. So that involved putting together a document to assess for having greater numbers of takeaways during the COVID pandemic. So it's a very similar kind of checklist to the existing checklist for takeaways, but it has just a little bit more detail to provide more nuance between a low, sort of moderate and high level risk that goes along with providing those larger quantities of takeaways. So now for someone who's low risk with methadone, for example, having up to sort of 6 takeaways a week as standard, and maybe a little more for someone who's got very, very long-term stability. And then for buprenorphine, having up to 13 takeaways a fortnight as standard, and even for those very stable people, being able to get a month worth. That is more than we've had before, and so to provide a bit more information about how you could document where you see clients fitting and what's appropriate for their safety and also for their social distancing. So that was one document that came out that's available, I think most websites. So HRV, PAMS links to it. The PABINs have a website that links to it. I think we can probably get those links in the chat box or sent out. And it is on the Department of Health website, though it's a little harder to find in there. It's under the COVID responses. So there was a document to assess and provide more flexibility around takeaways. There is a document there around third-party supply. So one of the big concerns is that if somebody was required to self-isolate, or if they in fact had a COVID positive result, that they wouldn't necessarily be able to get out of the house and attend a pharmacy. So we have a process now with a range of different checklists to support that process for third-party supply. So that could be for a known third party, somebody that the consumer themselves knows and trusts to deliver their pharmacotherapy to them. Or there's also the allowance for a contracted third party. So that could be a courier or it could be a health service that would be able to deliver those doses. And again, in those documents, there's a whole bunch of information around having sort of contactless delivery, but still making sure that doses aren't left unattended. So being able to sort of step back, make sure that you observe the doses are being picked up. There are some checklists around what a pharmacist should check before giving those doses to somebody. And there's also some additional documents that people can sign, really as proof that you've got consent from the patient. We certainly don't want this to happen without being 100% sure that that's what the patient wants for their dose to go with somebody. And also for the people delivering it in terms of being aware of that they shouldn't leave a dose unattended, that they shouldn't stop somewhere on the way and leave somebody's medication in the car unattended. Some of those documents, if you read the third-party document carefully, It is quite a long document, but there are things that are kind of musts in that document, and there are things that are documents that will support the process if they're helpful. So for example, it's not required that you get a hard sort of wet signature on a piece of paper, but that's one option to be able to do it, but you could also get verbal confirmation. So I think there's a bit of flexibility in that process, so that if someone is, for example, COVID positive, we don't want to have that contact be a requirement. But if a pharmacist wants to be able to document things, depending on the circumstance, they've got that. There was also a letter that went out to prescribers and pharmacists letting them know about these changes. There's changes to prescribers and the number of people they can prescribe buprenorphine to without training. So now that cap has been lifted from 5 to 30 patients, which should provide a bit more capacity in the community. And there's also a range of things that have gone on behind the scenes with the PABINs to try and shore up processes if a pharmacy or a GP had to close for a period of time. That was a very real concern that might happen. And so now that there's been a lot of work in the background to look at what would be a plan B for any particular pharmacy or GP, and where is their capacity to pick up if a pharmacy did or a GP did need to stop seeing people for a period of time.
Okay, so Sione and Sarah, what have you seen in response to those changes, either at the pharmacy or GP or prescriber end, or in particular the consumer end? Can you talk to that at all?
Yeah, so like particularly at the beginning, some consumers were going in, seeing their prescriber, having a discussion about additional takeaways. You know, quite often more takeaways would be provided, and then the consumer would go down to the pharmacy with a prescription. And if there hadn't been a communication between the prescriber and the pharmacist, sometimes the pharmacist will say, well, hang on a second, you're on 3 takeaways a week and now I've got this script for 5. You know, so how we've kind of got around that is really encouraging that communication between the prescriber and the pharmacist happens. And we're encouraging consumers to say to their prescriber, look, if, you know, you have agreed to give me more takeaways, could you perhaps contact my pharmacist and let them know? Because we find that really, you know, it makes the pharmacist feel a lot more comfortable. Some prescribers and pharmacists are kind of changing their practices, some sort of to a lesser degree. You know, some prescribers are starting to do longer scripts as an example. Others, you know, not so much. Telehealth is something that's really, I think, come into existence as part of the whole COVID thing. It's really interesting, telehealth, because I think a lot of consumers really like it and benefit from it a lot. And just through working on PAMs, one of the issues that constantly comes up is clients saying to us, you know, I've been trying to call my prescriber, I just can't get through. They won't talk to me. But now they've got that opportunity. So that has actually been quite positive. And the fact that because it's chronic, you know, pharmacotherapy consumers have got a chronic health condition, I think that means it has to be bulk billed, which is really good. Some of the consumers are struggling a little, and this is the minority, but some consumers are struggling a little bit with sort of less contact with service providers, and I think that's probably more those that have not huge sort of numbers of social supports and that sort of thing. And I think really, you know, what I've kind of learned from this is that there is sort of no size fits all. And quite often, and this is certainly the way that we work at PAMS, we've got to find the solutions that suit the individual consumer, but also suit all parties. So,
just may I, at that point, just we have a question from our audience. Anyone aware of harm to clients from takeaways? I mean, there is, of course, one of the key risks that that we try to manage is the dangers to others, including children, an overdose risk. Anything that you understand happening there, or that you'd like to comment on?
I can talk a little bit to some of, I mean, that was definitely something in the front of our minds when we were putting together these processes. And so I think it is, as was always the case, clear in the checklist that having somewhere secure to store takeaways is a key requirement for people getting takeaways at all, but particularly larger amounts. And so I think that's one of those factors that we have, you know, kept on people's minds is, you know, if you're going to give someone a large amount of takeaways, have a chat about making sure that they've got somewhere safe to store them. And that might look different depending on any individual's situation. If they've got young children, if they're in a share house, if they're on their own, that's all going to look different. I know that Sarah's done work with a range of different people, kind of workshopping solutions for how they might have secure storage. I don't know if you wanted to talk about that, Sarah. I haven't personally heard of any kind of concerns with the takeaways yet, but that's obviously something that, I mean, we know that whenever there's an incident like this, it tends to get a lot of media. It brings, you know, a lot of pressure on pharmacotherapy services. So that's definitely something that has been kind of, we've tried to be on the front foot about in terms of having that in people's minds.
Yeah, look, I think you're right, Suzi, and a lot of this is about education. I mean, I've, you know, sometimes been a little bit worried when I've spoken to somebody and they've like, oh, well, I've got my 3 takeaways in my backpack and they're with me all the time. And for that person, that's what they consider to be safe. Sorry. However, you know, like, it is really difficult for people who are homeless. One of the really good things that's happened through COVID is that a lot of people have been given sort of temporary accommodation, and I think, you know, it is a lot about education, really. And I mean, it can be a filing cabinet, it can be a drawer, it can be a cupboard really high up. It's about that safety and security, and getting that message across to the consumer group.
So on that then, can I ask, and we'll have a lot of clinicians online, how can AOD clinicians support pharmacotherapy recipients at this time? And it picks up on your point, Sarah, a little bit further,
Yeah. I mean, I think that workshopping that Sarah does with clients to actually think about a solution and having that when you go to the doctor, because often that's something that the GP or prescriber is going to want to know in advance, is what have you got in terms of secure storage. So if you're working with a client, making sure that they've thought through those options, and if they don't have an option, there are things like relatively low cost lockboxes or safes that might be able to be purchased. And I think knowing that that option has been thought through, and knowing that the client in front of them knows that that's important, I think gives a lot of confidence in having it, you know, be known that this is an important risk that we're already managing. And I think also communicating that to the pharmacist as well. So just being on the front foot and having had that conversation and having a solution ready just shows, I think, that we're all aware of the risks and we take them seriously.
And it's so much like, you know, with everything around pharmacotherapy, it's exactly that. It's balancing the benefits and the risks. And, you know, sometimes you have to sort of take a little bit more of a risk to get that benefit. And we're really trying to, you know, contain this pandemic as much as we possibly can. And I mean, you know, we all know how many people really that this consumer group is particularly at risks, and it's, you know, it's not easy, it's difficult.
Yeah, and I can see there's a comment in the chat about some of the options around lockboxes and safes from hardware stores. So, you know, I think, you know, particularly when there's children around, having those options in someone's home is a really great step, because the last thing any of us want to see is somebody come to harm when we're trying to increase people's safety, and that kind of reduce the flexibility we currently have.
Yeah.
Oh,
Can I ask, what about any differences between metro and rural regional Victoria? Thinking about pharmacotherapy and COVID-19.
Yeah, obviously one of the biggest issues that we find for pharmacotherapy consumers in the rural and regional areas is the distance that they have to travel. And public transport can, like, I mean, sometimes I've been just sort of quite horrified that there is no public transport on a Saturday or a Sunday. If people have got cars, that's fantastic. That's really sort of helpful. But I guess one of the biggest sort of risk factors in terms of COVID-19 and people on programs in rural and regional Victoria is that there quite often is only one pharmacy for a really long, a considerable distance. So if at worst case scenario, that pharmacy had to, even change its dosing hours, that can really sort of upset the apple cart, so to speak. So I think it's the issues are the same. They're just sometimes more exacerbated, and that's often due to the scarcity of services or that sort of thing.
Yeah. People may or may not be aware, but the pharmacotherapy area-based networks have been doing an enormous amount of work behind the scenes, ringing literally every pharmacy and prescriber that they've got on their books to check in about what plans that they've got, if they might need to close, if they would be willing to take on extra patients, to make sure that they've got up-to-date contact lists. And there are now checklists on the PAVN website so that pharmacists and GPs could go through some steps to kind of work out what might be a plan B. And also just do things like make sure that for every pharmacotherapy client on their books that they've got up-to-date contact information, that they've got a good recent photograph, that someone who didn't know them would look at the photograph and be confident that they've got, that is the right person, trying to make sure that people have some kind of ID, so that if, for example, you had to go to a new dosing point, all of the records are up to date, and that would make it much easier to do a handover in that case.
So I might move, oh, sorry, Sarah, did you want to say something?
Right, I was going to say, just on Suzi's point, one of the things that we're encouraging the consumer group to do is to store those phone numbers for their clinic and their pharmacy in their phone, so that if the pharmacy is ringing them or the prescriber is ringing them, they won't say, sort of think, oh, I don't know who that is, and then not answer. Because if your clinic or your pharmacy is calling you, there's probably a pretty good important reason, and it's a phone call you don't want to miss. But I can't tell you how many times those calls are missed.
Yeah. And I know a lot of clinics actually ring with hidden numbers, so it looks like an unknown caller, which can just be a barrier to be able to get through to people as well.
Mm.
Text message.
Thank you. Okay, so I might move towards some outstanding challenges. And Peter Werns asked a question, which, Suzi, you'll be able to answer this. Is there any movement on subsidising the administration fee? So what was there any thinking in that dispensing fee and managing that at this time?
Look, there's been a lot of discussion with the department as well, and I know that they're very sympathetic to the fact that many people in our community have got more financial pressure now than ever before. There's less employment around, a lot of casual employment has dried up. So there has been a discussion around the fact that those people who are trying to come up with these pharmacotherapy fees at this time might be under more pressure, and also that there might be a range of other situations where pharmacotherapy fees might need to be subsidised. I haven't heard of a clear outcome of that, but I certainly know that that message has been very clearly conveyed to the department, and they are doing what they can from their end to try and look at what options might be available in that regard. It is a really clear pressure that could potentially be alleviated with that broader goal that I think was everyone's goal in making sure that we had continuity of treatment during this time for people in pharmacotherapy. So that's the overarching goal that's driven most of the things that have happened in the COVID response. So,
okay.
Yeah.
So Sione and Sarah, thinking about that as a challenge, and any other outstanding challenges?
Well, there's been a bit of an influx of people wanting to get onto the program.
Yes.
I've certainly noticed that at PAMS, like a couple of weeks ago, almost every second client contact we get was somebody wanting to get onto the program. Interestingly, and I'm really not quite sure why, but that has eased off a little bit. Yeah, so it's So, yeah, and I guess getting the other issue that I wanted to mention was just getting ample supplies of naloxone out to people that's still a bit of a challenge. We all want to do it and we all know how to do it, but particularly with increased amounts of takeaways and that sort of thing, it's actually getting that to happen in the context of physical distancing and that sort of thing is a bit challenging.
At the moment, a prescription is still required. Well, it's not required, but to get it at a level that's affordable for most people, prescription is the best way to get naloxone. And so engaging in that conversation with people whilst they're getting like increased takeaways is a clear opportunity. But of course, it's important as well to have that conversation in the context, in a context that that's about safety for everyone. And because I think people feel very often can take that sort of thing the wrong way. But naloxone is not just about keeping yourself safe, but keeping everyone around you safe, and giving just a little bit more, just making people feel just a little bit more comfortable about having longer scripts and extended takeaways.
Yeah, I can also see there's a question about the cost of naloxone. So there is the Victorian Department of Health and Human Services have a program where some pharmacies can provide it for free, so they'll get that stock sort of reimbursed through that that program. I don't know if there's a really clear or up-to-date list of which pharmacies are doing that, but I think kind of tracking that down and circulating it would be pretty key at this time, because that cost barrier, if you're buying it over the counter, is obviously quite significant. And I also don't know that it reflects good public health if you kind of have a cost barrier to buy a medicine that ultimately you might be buying for someone else. So, you know, it's really a public health service that someone's providing if they carry naloxone on them, and they shouldn't be paying for that, in my opinion.
Yeah, there are certainly funded programs that exist now, and one of the best ways for people to, and even if people are on pharmacotherapy, they have an option of getting it through the doctor, through their prescriber, but accessing it via NSPs is now feasible. It's not likely that you will have it handed over to you directly on the spot, but a number of needle and syringe programs and a lot of the specialist drug services around Melbourne have workers who are focused on that and make it as easy as possible and as barrier-free as possible. That might include a voucher to be able to go to the chemist and pick up the naloxone, and then it's basically paid for you via a program that the department have funded. So it's feasible, but there are still little humps and barriers for people that are quite actually significant when you've got a number of other priorities every day.
Yeah, and we do look with a little bit of envy at those states that were lucky enough to be in the current naloxone pilot, where they can just pick it up for free from the pharmacy and a range of other services. So hopefully we're moving in that direction. And I can see that there's a kind of question comment about getting the list of pharmacies. That's probably something that could happen as a follow-up, is to check in with the department about if there is that information that can be available, or I guess if there's somebody within the sector that could hold that information if it can't be published.
So I want to keep moving on if we can, and ask a question about long-acting injectables. What's their role here at this time?
That is a great question. It's been a topic of much discussion, particularly because there's such a new treatment option in it, like at all. And it's something that most of us are getting experience with. There's still currently trials that are ongoing in Australia, gaining that experience. So on one hand, it's really great to have an option that doesn't require daily pickup at the pharmacy. On the other hand, we're still actually getting a handle around which patients do really well with this, which patients like this a lot, who might it not be an ideal option for. And also in the context of if somebody was COVID positive, in New South Wales, for example, the practice is that they wouldn't have somebody go and administer the depot to someone who is COVID positive. So then those people would get a bridging period of sublingual buprenorphine. That's what I believe is the process in New South Wales. So there are a few kind of little subtleties around how it might be delivered that are not perfect when you're trying to reduce the amount of physical contact. But again, seeing someone once a month is much easier than going to a pharmacy every day. But I think it's a very individual decision between a consumer and their healthcare team around whether or not that's the right option for them. Yeah. I know Sione and Sarah probably had a lot of conversations about this.
Yeah, I think one of the issues with the long-acting injectable is that in the whole scheme of things, I mean, we've got so much experience with methadone and now, you know, buprenorphine and Suboxone, but we don't really know a lot the consumer perspective on the long-acting injectable. And obviously, we will absolutely get there, but I think I guess I'm a little bit, and this is just really me, I suppose, but I'm a bit nervous about starting something new in the time of a pandemic. I'm also worried about consumers being isolated. I remember, I guess, when we first implemented buprenorphine, and there was so many questions from the consumer group. It was just a hell of a lot of need for information and support and communication. If people are isolated, I guess I'm a bit concerned about how we can make sure that they get access to all the information and I guess the support, the conversations that they need, having someone there to be able to answer the questions and concerns and put their mind at ease.
Yeah, I think that might be a little bit of a challenge at the moment when I think it does actually feel like the pressure is off a little bit compared to the last few weeks in terms of being able to access our healthcare professionals. We know a couple of weeks ago, people were just under such intense time pressure that being able to have those detailed conversations to really get that information was quite hard. I think that's easing off a little bit. I think in general, what we're hearing from people who've had the depot buprenorphine is for the majority of people, they have really found it a great option for them and they're quite happy on it. A very small number of people have found challenges, but I think it's more around, I guess, a fear that people will see that as something to push people towards to reduce attending pharmacies. And I think it's kind of, I mean, this is just my opinion, but I think if it's something that the consumer really wants to try and it seems clinically appropriate, that's great. But I don't think I would necessarily endorse a really large push towards something that we're still getting experience. I think it's great to be able to take our time, get experience with it with patients who are really keen to try it. And then, I guess roll it out in an appropriate way. I think it's great that we are rolling it out, but it's just one of those things that we don't want to rush.
So don't get too far ahead, Suzi, because I want to ask one of my last questions is going to be around what have we learned and what would we take forward from here. But otherwise, what are some of the broader implications for understanding treatment here? What do you think about that? Is there something that you could talk to in that space?
Well, something we were having a bit of a chat about just yesterday actually was around this idea of kind of low threshold treatment and what happens. There are a group of people that don't necessarily want to be in treatment, be abstinent, be stopping all their substance use, but they might be at great risk with changes in the drug market at the moment. They might want a break from having to go out into the world every day, and that having a short period of being able to stay at home with something like buprenorphine might be a really good solution for them. And I guess that's something that's not necessarily, doesn't fit perfectly into our current treatment system. We're lucky that at the moment, I guess, things are looking pretty okay in Australia in terms of where things are heading with COVID. But if that changed and if things got a lot more severe, or if we saw these real changes in our drug market that have been foreshadowed, that we might need to be able to get a lot of people into treatment as a way of preventing significant opioid withdrawal. And we aren't necessarily set up to do that right now in terms of treatment capacity, in terms of getting people into treatment without seeing them physically, if we're doing telehealth, and that might present some challenges that we want to think through. And also around, when someone's new in treatment, that's typically when we have the highest level of supervision and attendance at a pharmacy, and how that can be flexibly done. Sorry, I'm stumbling over my words. And an example that I've seen a lot internationally is this kind of New York model where people can get telephone buprenorphine at a home induction with a week's supply. Now, obviously what's going on in New York at the moment is dire and things are very severe, and they've had to come up with options that are well outside what we normally do. But I think that they've got a lot of experience with home induction in New York in general. They don't require people to have a first dose in a clinic or a pharmacy, and they've been able to scale up those things. And I think it just highlights that there are some flexible options we could explore in the future for our people who are in rural areas where getting to a GP might be tricky, and maybe we don't want to go all the way straight into these options, but just think about how we could expand the way we do things to be more flexible, learning a bit from those international examples.
Sione and Sarah, do you want to pick up on low threshold treatment at all, or anything that Suzi's mentioned there?
Yeah, in that context, we know we're already seeing, I'm sure participants to the seminar or webinar are also already seeing and understanding there are changes to the drug market, and that in itself, that fluctuation in the drug market can obviously have downstream effects and can impact on drug treatment and the people's need for it. And very often we've got a discourse really around treatment as being about cure and abstinence. And although harm reduction is absolutely moving more and more into AOD treatment and programs as a whole, it's important to remember that pharmacotherapy in many respects started as a harm reduction approach and was about framing treatment as a good thing to keep people safe. And particularly in our circumstances now, when we don't know exactly what's going on with the drug markets and drug supply, and everything we've heard is that quality is fairly is fluctuating at the moment, and that can increase risk of overdose and so on. Perhaps being able to frame drug treatment as being partly, for some people, about actually keeping them safe when drugs are not around, rather than actually having to enter into a process where you're now going to stop drug use forever, because that's just not right for many people. And I think that that's where the idea of low threshold and harm reduction sort of treatment might come in. And there are, as Suzi mentioned, and Sarah knows as well more than I do, that there are different versions of that around the world, but certainly it's about making it easier for people to get onto treatment and to get those first doses in particular, rather than making it harder, which is sometimes how it feels as a consumer, is that although I think the sector in general wants to make things easier, it still feels like accessing treatment is quite hard, and regardless of what kind, but particularly pharmacotherapy, unless you've been on it before, it's hard to know where to start and all that sort of thing.
Yeah, and I mean, I know already that AOD clinicians work with consumers around their individual goals, but it might just be that some of the goals that people have at the moment is really just keeping safe in a time of an uncertain drug market, as opposed to staying off drugs in the long term, and that, you know, what we see during the pandemic might be a little bit different from normal in terms of who comes forward and what their needs are.
Okay, so I want to wrap us up soon. I think we've got another few minutes, 5 minutes or so. Unfortunately, Nguala couldn't join us, which is a shame, and hopefully we can hear from them in a later webinar. But I'm keen to hear from Rob Campbell too. I don't want to eat into his time exactly. So we have I might do a couple of rapid fire questions, and then I do want to hear about where to from here. So, any intelligence on the situation for the Aboriginal community members, quickly?
It's not something I can comment on. I don't have a direct kind of.
Okay, that's okay.
In that area.
I think what we know. Okay, so what we know is that generally speaking, situations like COVID-19 and drug treatment shortages, or feelings of drug treatment sort of insecurity, absolutely impact on Aboriginal community in a disproportionate way, partly because many health issues do. And what we know as well is that, unfortunately, there are Aboriginal people are overrepresented in our homeless community, in our rough sleeping and homeless communities as well, especially around the inner city. And what we know, to be honest, is that this community has been over-policed during the COVID-19 period, and whether that's because people, more people are actually isolating at home, and therefore people who maybe aren't strictly homeless and can theoretically, people who have nowhere to sleep or are transitory shouldn't be getting fines and so forth, but we know that people have been. And even if people aren't getting fines for COVID, we know that they're being searched and over-policed around drugs as well at the moment. So I think that when we talk about our Aboriginal community, that's something that we always have to remember, is that nearly always they are overrepresented and over impacted in these ways, in those ways as well.
Thanks, Sione. Well said, Sarah.
Yeah, I was just going to add, when I was looking at the issue around bulk billing and telehealth, and just simply being Aboriginal or Torres Strait Islander can automatically means that you have to be bulk billed for telehealth, which I think is really good. As are people with chronic health conditions, but yeah.
Okay, thank you. In the last couple of minutes, I'll take one from Dave Taylor on SafeScript. Has it had any impact on engagement numbers, and how has it been used, if at all, in interactions with clients? Can you make a brief comment on that?
Well, we'd have to ask our friends at SafeScript if they're able to share data on that. That's not something that we have visibility on. There has been, I guess, a few things that we've learnt in terms of some of the assumptions around SafeScript that maybe there's a role for a bit more education. So number one, it seems that there's been a range of incidents where pharmacotherapy scripts aren't appearing on SafeScript, and that's provided challenges in hospital settings where they haven't been able to kind of confirm what a consumer is telling them in terms of that they're on a medication. So I guess that reminds us that it is really important, if people are relying on that as a source of a record that someone's in pharmacotherapy, that it's not necessarily complete. And the other thing is, I think there was a query yesterday suggesting that some people assume that actually daily dosing would be reflected in SafeScript, which it isn't. So you still really need to be able to talk to a pharmacist to confirm when someone had their last dose and what that dose was. So that isn't something that you can necessarily get from that SafeScript system. So that's something that people have different understandings of. And so we definitely don't want to get into a situation where someone's been accused of saying that they've had something, but the SafeScript says they haven't, and that some of those communications are really important to ensure that people actually understand what that information can tell them, and that there are some gaps in it. And so sometimes we do actually have to be ringing around and getting extra information that's not necessarily all in the system.
Okay, so then the last question, if I can, to you in the last minute or two. What have we learned and where to from here? What would you take forward? There's been some guidance changes. Do they stay? Do you want them to stay? What and practice changes? What do you take forward?
Look, personally, I would really, I mean, I know that the new sort of the guidance is supposed to be just for the COVID-19, but I think particularly the focus on the assessment in terms of takeaways, I think is really good. I think the third party pickup is going to be useful ongoing, no matter what. There are so many different circumstances where that's incredibly useful. I think the longer scripts, there's plenty of situations where that will be absolutely invaluable. And telehealth, and I think, so they're the things that I would love to see continue into the future. But I think one of the really good things is the way that we've been able to respond to this pandemic so quickly and get some really good documents is really a testament to the really amazing people that are in this community. So yeah, that's
Thanks, Sarah. Yep.
I would echo that. I think the process of developing a response that happened here, I think that having that and being able to use that process again, should something else happen, it worked very well. And so I think that was good. And also, I guess some of these documents, they are COVID specific, but keeping them around for all of the other kinds of crises that we might expect as well. So, regionally kind of specific things like a bushfire or a flood where people might have trouble getting access to treatment, all these same processes that have been not only developed, but now that we've got some experience with, we could probably fine tune them with some feedback and having them be more general responses that we can put into place whenever we have access issues or, crises that require this kind of response. So not having to start from scratch.
The final thing I'd add is probably just to echo the question that Peter asked before, and that's that, or echo around that, and that's that I think that this is a great start, and if we could push the boat out a little bit further and help support some of the most marginalised people in our community who can't afford pharmacotherapy, where someone like me with a job certainly can. I don't know that, I think there are ways to help people with the cost of pharmacotherapy without having to pay for everyone's, and to maybe think a little bit innovatively in the way that we've had to over this period in time, and seeing that it can work, and hopefully the guidance will stay as well.
Yeah, and this situation has shone a very bright light on some of the vulnerabilities in our service system, and I think that when all of this settles down, to maybe pick up on some of those other vulnerabilities that were identified that couldn't be resolved immediately, but we do need to pay attention to.
Thanks, Suzi. Well done. Thanks, Sione. Thanks, Sarah. Really appreciate that. Really appreciate your insights. So thank you for joining us today. And back to you in the studio, Beck.
Thank you.
Thank you.
Thank you. Thanks, Scott, Sione, Sarah and Suzi. It was they were really fantastic insights, and we really value your expertise. And I keep talking about the COVID silver linings and an opportunity with a government who wants to act very differently and a department who wants to act very differently, how we actually not only push the boat out, but, kind of sail it across the ocean to get what we want. So it gives me great delight now to introduce Rod Campbell, who is our next speaker. He's the Program Manager at Family Drug Help and Shark, and has been working in the human services field for over 25 years across a number of fields, including AOD, gambling, men's behaviour change and family violence programs, couples and family work, community health, brain injury, acute and ambulatory services. His qualifications include a Bachelor of Arts, a Master's in Social Work Management and Human Services, a Master's in Counselling, a Graduate Certificate in Family Therapy, a Certificate in Workplace Training. He's also been involved in research projects with Beyond Blue, Deakin University and Our Bias. So Rob, I'm really looking forward to hearing some of your insights and expertise, and that's a fairly impressive record. So and bio. So I'm delighted to hand over to you, and between us, yourself, myself and Vada Meetings will moderate the questions, but over to you, Robert. I'm going to turn my camera off and mute myself.
Thanks, Beck. Welcome, everyone. Look, this is an amazing time, obviously, and I've got the global perspective behind me. As you know, in this time, so much has been compressed, and yet it's a chance to have a bigger view of what's been happening, and in particular, obviously, with families being so important in the experience of people who are being confronted by AOD use, they're grappling with addiction, or in terms of what they're doing in their lives. And the family perspective that we bring at Family Drug Help really is a way of looking at the big picture around what supports are available for families, because we know that when families are well engaged, when families are part of the picture, we can get better outcomes for the clients that we're seeking to support who are addressing their own substance use. And I think that the exciting thing that we've seen with COVID-19 is that with all the challenges, there have been a lot of exciting possibilities. So I thought I'd just give an overview of some of the things that we've noticed. For those who don't know, so Family Drug Help is a statewide service that's part of Shark, and we run a number of programs. We have a helpline that's staffed by trained volunteers, which gives that lived experience, that personal peer connection for people who are grappling with the impact of substance use in their families or their friendship networks. We also provide an extensive range of psychoeducation programs. So in Focus, Breakthrough, working with ICE Education for Families in collaboration with Turning Point. We have counselling. We have an exciting new area working with gambling. So working with families impacted by gambling, which we know there's a strong crossover between gambling, mental health, AOD, and family violence. And some exciting other areas working with the Muslim community with the MIAF program as well. So we have an exciting way in which we're connecting, but with the COVID-19, I thought I'd just talk about some of the things that we're noticing. First up with the helpline. Everyone's, families are struggling at the best of times with the impact of substance use, but with the COVID-19, that's just been intensely compressed both in time and stress for families. With lockdown and with the exposure to having to be in a closer family unit at times, that's increased the levels of stress. There's financial stressors, but obviously too, a lot of concerns around family violence, which are emerging, and how families can best respond to that. There is no simple answer, and the most important thing is in being able to connect with families, give them a space in which they can explore what's actually happening for them in a safe and non-judgmental way. And we're clearly seeing that the impact on their own privacy, their own sense of being able to experience what's happening for them and to even communicate is compromised if the person who's also have a substance issue is living in the home as well. And we've seen that that's been a major challenge for a lot of families. A lot of people are getting in the car and having counselling sessions through the car or going for a walk as well. Of course, for a lot of people, that's not actually an option. They can't physically get out if they've got young children perhaps, or the weather, whatever it might be. So there are a lot of different issues that are definitely affecting families. One thing that we're too noticing is that there's that sense that as families are being held closer together because of the COVID-19, they're suddenly being aware of a lot more of the substance use that's actually going on. So what they thought may have been just recreational use or weekend use is actually a lot more entrenched. And of course, this is being exacerbated by their own stress too. So substance use in terms of even prescription meds, we know about the widespread reporting of increased alcohol use, which is a strain too. And then families themselves would be looking at their own coping mechanisms. And we've seen situations where their own alcohol use to manage the stress in the family unit has become an issue too. So it's something that ripples across the whole family unit. But we're also seeing too that the restrictions to social movement means that what they would take for granted in their opportunity to get out and have some time away is affected as well. So going to the films, going out for tea, things that they would normally do as part of their self-care, those options aren't available. So it's really been important for us to focus on their own mental health and looking at what they can do to provide support for themselves and within their own social networks. So we've been focusing a lot on their own ways of improving their mental health. Obviously, exercise has been really important, but also too in terms of strategies for communication. We know that families, when confronted by the impact of substance use, respond in three typical ways. They're quite angry about it and want to confront the person or the situation. There are others that are wanting to just keep the peace, just hope that things settle down over time. And there are others that just want to withdraw and have nothing to do with the situation. And with the COVID-19, this has just been exacerbated. So the stressors and the tension within family units that we're seeing through the helpline is greatly increased. And that obviously then creates a lot more tension in family violence situations as well. So in those situations with the helpline, we've been really looking at what's their locus of control? What are the things that they're able to focus on? When is it a good time to have a conversation? Is this only going to be something that maybe exacerbates or makes the situation worse? And really looking at what their options are, exploring how they're approaching the situation and looking at what other options there are for support. It's been fantastic, again, from a global perspective around the goodwill and the collaboration that we've experienced with other AOD services and across other sectors, gambling in particular, mental health, and obviously family violence too, because we're all in this together, and it's an extraordinary situation that people haven't encountered to this extent in terms of the impact on families and for those obviously who are using too. So it's been a really important way of being able to make connections with other services that people can be a part of and can get support through. But I think through the helpline, overwhelmingly what we get is the sense of connection and that they can speak and just be heard without judgment. Because there are a lot of complex feelings around grief and guilt, even issues around how boundaries would be managed. We talk a lot about the importance of personal boundaries and what's our thing to consider and what's maybe the other person's issue to address. But when this is all compacted into a home environment, that's a little more tricky to navigate. For example, it might be that it's perfectly appropriate for someone to ask someone to leave the home. But then there are concerns around potential homelessness, what they might be exposed to in the community, or the lack of housing that's available. And so can generate a lot of feelings of uncertainty, guilt and grief around those things too. We also see that the issue of people wanting to get help, even though there are increased services, some people are reluctant to do that as well. We're getting reports from family members that just as they're about to make a call, or if they're in the middle of a call, that the person that they're concerned about, or where there's conflict, could walk into the room. So there are times where we've had a drop-off of calls as well, and people have been making contact through email or through other ways of getting support. So even the ability to have your own safe space in which to reach out and get help is compromised. So as a result, we've really looked at different ways of being able to provide support for families. So the helpline, even though we've had to work outside, so keeping the phone line operating, but through off-site, that's been a really important thing, and as a service that's remained unchanged. But the other ways in which we've provided support we have modified. So obviously, like everyone else, we've been grappling with different ways in which to provide an online platform. So we've been providing examples of a Google Classroom. So with the In Focus program, which is typically a 6-week program that explores in depth issues for families around the understanding addiction, patterns of behaviour, looking at communication strategies, safety plans and what have you, and ways of being able to move forward in their lives. That is typically obviously a group that's done face-to-face within a group setting. So what we've chosen is a model that works with the Google Classroom. So people have the opportunity in the privacy of their home to look at that content and then have an opportunity to connect up at a Zoom session. So that if someone walks in, they can just shut down what's on the screen. It's a chance just to read up on material. And that's actually been picked up quite well. And that's providing another way of a flexible approach, I suppose, for families to connect. Another approach we're looking at with Breakthrough is the online delivery via Zoom. And that's proving to be an exciting new area because, again, families can just have the opportunity to ask questions, have the information presented, but done over time as well. One of the important areas we have in family drug help is the use of support groups. So support groups are a way for people who really want to see how others are coping, get education around coping strategies, but also the opportunity to share and connect so that they're not in that sense of feeling alone. Obviously with COVID-19, we haven't been able to do that, but we've done that online via Zoom. And that was an area that we had some reservations about in terms of what access people might have to that technology or even comfort using that. But to our surprise, that's probably been one of the most successful in terms of the uptake of technology in that way. So we're using support groups via Zoom, and it's proving to be, even though Zoom has that two-dimensional aspect to it, and you don't have that nuanced sense of warm connection with people, there is still that ability to connect, and that's really valuable. And with the function with Zoom or any of the other platforms, the ability to share screens or share videos as well, so that we can still have an educational component, but also that sense of the group connecting. So that's been an unforeseen benefit for us. The counselling as well, we're seeing some degree of uptake with Zoom and telehealth, but there are those who still prefer the face-to-face contact and support. So it's really one of those things that we're just trialling and exploring, but there's definitely a real sense that people are reaching out, wanting support, but that they're under such enormous stress that they've not really encountered before. Some of the other flip sides to that is that we're having reports from families where things have been improving because they've had a situation where their loved one or family member in that space is actually doing well in their recovery despite stressors. By being home, they're not having the usual triggers that they would have when they're out, that they're actually engaging well and feeling well supported through telehealth, and that they're actually engaging more than they were when it was face-to-face sessions, whether that was because they had to use public transport or other issues around just getting to a particular site. So people are finding that for some that the communication between members has actually improved. And we know that when families are well supported and they develop good communication strategies and are able to work within that family unit, that you can get amazing outcomes, or outcomes which allow them to have more ownership around their own experience. And we know that there can be such transformed relationships, and that's why we have the psychoeducation programs around In Focus, so that people can move from feeling stuck and hopeless and fearful to being more in a space where there's actually opportunities for relationship building and rebuilding and connection moving forward. And I think that Zoom and obviously the ongoing support of the telephone helpline has provided a really valuable way of providing that connection for families as they then look at their own needs and develop their own connections as well. One of the other things too we've noticed is around social distancing, even that opportunity to meet in a neutral place. So looking at how families can have those connections with people again has been affected. So families have been using obviously telephone, Zoom themselves, but it's not quite the same going to a neutral place like they would in a cafe or a restaurant, which they may have done. So families are really noticing the impact of not being able to have the social capacity to connect in the way that they used to do. But hopefully the way things are, that this will start to ease up, because clearly, you know, it looks like things might be, we're getting to a bit of a light at the end of the tunnel with this. But with that, it's given us a lot of insights into how we can move forward, especially with remote communities and country and rural areas, but also people who live in Melbourne who, for whatever reason, aren't in a position to attend a group or access service. So Zoom and this way of working, whichever online platform you use, is providing an amazing way of being able to connect. And we've had that experience with Tumut, which is a small community in the Snowy Mountains, which we'd actually set up a support group with them remotely before COVID-19. And that almost gave us insights into ways of being able to make that work. And so it's just demonstrated that really our way of connecting and providing support need not be limited to site-based areas. Even though that's important, it's a great way of also dealing with those issues of shame and stigma, especially in country towns where people don't want to necessarily be seen or known in that particular thing. Ironically, of course, everyone knows what's going on, but in another way, they don't want people to know what's going on. So it's one of those paradoxes which this way of connecting is certainly being able to provide a way forward. I think that too, the ability to be able to provide support across a whole lot of other different platforms. So I mentioned before around supporting families affected by gambling. We're setting up a gambling support group as well in the same way with the Zoom platform, and working with families that are recognising that there is no neat aspect around what they're dealing with, that it covers a whole number of different areas, and that we can provide a huge number of different supports in that space. So really, COVID-19 has obviously been a huge global issue for us all, of course, and how we've all managed to respond. But as a service and as a community, I think that we've done exceptionally well. And as an AOD sector, I think that it's been a really exciting time from the point of view of how we can learn from this and how we can move forward. And I think that we'll certainly be using a lot of this moving ahead. Obviously, nothing beats also the face-to-face, and that's such an important dimension to treatment and support for families in particular, but obviously within the broader AOD sector. So really, there's sort of some reflections on what we've encountered and where we're sort of looking to go into the future.
Thank you, Rob. Oh, excuse me. We don't have any questions at the moment, but I was interested in, I guess that I call it like the trilogy of, you know, kind of all the, you know, it's nearly a square when we talk about mental health, alcohol and other drugs, family violence, and gambling, and we know the interface and the intersection between those. I guess from my services experience, providing every single one of those services, is that we're yet to see the predicted tsunami, for lack of a better word, that we're seeing, that we're likely to see. We've seen probably a little bit of increase over the last week, but really our numbers have remained steady. How do you think that alcohol and other drug services could utilise some of your expertise? We don't want to overwhelm you guys with, you know, every family in Victoria suddenly wanting to access your service, but just some general things that AOD service providers or clinicians could do to better support families during this time.
Sure. Look, one of the models that underpins our approach in family drug help is the 5-step model. So it's a model that's been developed in the UK, which is a very engaging model around acknowledging the needs of families, looking at what supports and coping strategies they're using, what supports are available and how to move forward. And sometimes for families, that is a really important thing around just being able to be contained and just to be able to be heard, and looking at what is their stuff and what's not their stuff. And there are some great resources on that if you look up that particular model, because there are a lot of online resources too. In terms of supports, obviously giving us a call as well, and we have some information on our website too around different supports and options for support too. But also in looking at how families might want to be supported. So again, referring them into this, because the model of family drug help is around the concept of peer support, that people aren't alone, to normalise the fact that this is obviously impacting a huge proportion of the community, thousands and thousands of families. And I think that when families feel isolated and not sure where to go, but being a conduit around being able to open up different possibilities of support is a great way to be able to do that. But as you know, there is no magic bullet. There is no simple solution to this. It's for some families, obviously those who've just found out that they're maybe a young person in the family is using drugs for the first time and they're freaking out on how to respond to that, to the other end of the spectrum where it's been a chronic condition that's been managed in the family for a long time. Again, there's always support and there's always ways of being able to move forward. I've just got a question from Stefan. Have we run any open online groups with new people attending each week? Curious about how participants feel about meeting new people online for the first time and fears about their privacy. That's an excellent question, and we've definitely addressed that. So with our protocols, with the support groups, for example, we are, yes, getting new members and all the time. And the way that we manage that is that we take the referrals. So we don't have an open link for people to attend any group. The important thing is that people's privacy and their safety is paramount. So we send out a sort of a protocol, for want of a better word, around their safe use of the Zoom. A peer lead will make contact with that person and then send them a link to that meeting. So it's not something that people can bomb into from anywhere. It's only when they've been contacted and then that particular link to that meeting. And of course, with Zoom in particular, people have the opportunity to change their name and so not even have their name listed, and they can choose not to have their face screened as well. So there are different ways, or people can just come in by telephone. So it's not something that people need to feel that they're up. But equally, for today's presentation on the webinar, we were keen to get consumers' direct experience. And although a number of consumers were really interested in giving their perspective, there were obviously concerns, especially when I mentioned that it would be uploaded to YouTube and be out in the greater cosmos, that obviously people's concerns around privacy meant that they didn't want to participate, but they were very keen to get their perspectives heard. So the best way I just got a question, what's the best way for a family member to access FDH initially? Would be to ring the helpline. So that's 1300 660 068. Or if they jump on our website at shark, so shark.org.au or familydrughelp.org.au, they can send us an email and we can make contact. So we have different ways of providing support as well. So we can provide follow-up calls or we can send out information. So anyone who calls us, we have raft of different resources that we send through to family members, ranging from mental health supports, family violence supports, different ways and strategies of managing circumstances. So there's a whole lot of material that we can send out. So really, in terms of the broader AOD sector and looking at how they can support family members that they're working with indirectly, they can shoot us an email, we can send those resources out.
Thanks, Rob. You very interesting, and living in a smaller regional town. I know that you know, I've been at Primary Care Connect for 18 years and in the drug treatment, so it's just always been a challenge to get a face-to-face group going. So it's great to see that we've got other ways. Just wondering, though we couldn't get any family members online with us today, whether you could share some perspectives about things that they're noticing, and whether they've seen a change in the service sector, and what are their thoughts about some of the things that some of the things we've all had to do to change to meet COVID restrictions. So I was just wondering if we can't have them speak to us, could you speak on their behalf?
Sure. Look, I think that one of the interesting things, one of our family members was talking about the benefit of the telehealth. So that's been really well received, especially from psychiatrists, GPs, pharmacotherapy providers as well, so that there's been that opportunity for connection, and that's actually enhanced engagement and actually enhanced their ability to engage in treatment, those people who are actively looking at their own recovery. I think that there's a lot of confusion as to how services can be accessed. Obviously, understandable limitations on access to withdrawal and rehabs in light of the social distancing and that cohort of quarantine. But I think that families are certainly, to an extent, frustrated in that they're under increased stress and they're wanting solutions to really intractable problems, which at the best of times are difficult to provide in a timely way. So a lot of it is about that containment and putting things in that perspective, but also to recognising that there is a lot more that's been put online, and obviously the federal and state governments are putting a lot of money into providing more online supports and telephone supports. So it's also making people aware of those things too.
Thank you.
And another thing too, in terms of families, I think that the AOD sector, it's obviously well understood how important the family is, and there are family services in all of the different catchments as well, in terms of whether that's family counselling or how families can be engaged. So I'd encourage obviously those AOD sectors in terms of their regional areas to be able to provide those supports to families.
Thank you. So I'm just going to give a call out for any last questions. And you kind of touched on it, but what are the things that, kind of the top three things that Family Drug Help and Shark will be carrying forward post-COVID to borrow Sione's analogy, to push the boat out a little bit further?
Yeah, look, absolutely the use of Zoom or whatever platform we choose to use. As a way of providing support to remote communities and rural communities, definitely that. The importance of using Zoom to support the peer leaders. So in our support groups, they're actually led by peer leaders. They're not led by a facilitator who's a staff member or trained facilitator in that way. These are peer leads who have that ability to lead a group, who are trained up to do so. And what we've found is that they've felt much more connected as a group of peer leaders across the state because they've had that opportunity to connect. So that's a really important thing that we'll be promoting. And also being able to provide online groups to people who can then do that at their leisure, because I think that provides a lot more flexibility than where we would normally run a group once a week over an evening period. They can then do that at their own leisure and then ask questions directly.
Well, thank you, Rob. Those sound like great things to take forward, and I'm, kind of mulling over in my brain around some of our chronic conditions programs and what that would look like in Google Classroom. So thank you for that. I'm going to steal your idea. That's wonderful. So I wanted to thank Rob very much for your insights, and I think families are sometimes forgotten, but I do acknowledge that the AOD sector are very good at trying to ensure that the family are have a focus whenever we're working with our consumers. So thank you, Rob. I just wanted to wrap this up. We don't have any other questions. So thank you for everyone's attendance today. Thank you to our previous panelists. Thank you to Vada. Again, I think this was really worthwhile. So I'm going to give a shout out to our third webinar, which will be on the Thursday, 1st of May at 10:30, and we'll send out the details via e-news and on the events calendar on the VADA website. So as I said last time, again, thank you everyone for your hard work. We're offering different service types. We're checking in on our clients, and again, really trying to push some of the things that we've been known for a long time that have been barriers to treatment. And I think that it's actually astounded me how quickly government and the department can move when they need to. So I think we need to keep that momentum going. So thank you so much, everyone, for your attendance. This will be going up on the YouTube channel Vic AOD, and I hope you have a wonderful rest of the week. Thank you. Bye, everyone.